Yeah.
So Dr. Tu, you mentioned about the margin when we performed in the malignant nodule. So how much in that we need?
It's very difficult. It's very difficult. You get 1 mm, you're happy. You get 2 mm, you reach for the moon. It's truly difficult, and I struggle. I struggle when I do PTCs more than 1 centimeter. I try not to do them, but they somehow get sent when they don't want surgery. It can be very tricky. Be careful. My only advice is, don't be afraid to stop and come back. I think using CEUS, as some of the other speakers have said, it is quite interesting. It's just that right after ablation, when there's a lot of gas locked you, sometimes I'm not too sure whether I can trust the CEUS, but at interval CEUS and coming back may not be a bad idea.
Yeah. You mentioned about the informed consent. That's very important, right? So they have a chance of coming back to us.
Yes, exactly. So you have to tell the patient that you need repeated procedures, and of course the risk of future cancer. And I was having a side chat with Dr. Lin and on the chat is that I do predict that in the coming years we will start getting reports on cancers that we miss on ablation. Now, whether if that translates to overall survival, we don't know. We might never know simply because thyroid patients live forever. Certainly, I have come across a surgical paper comparing patients eligible for ablation but went for surgery instead. They pick up like 15% of cancers. And I do predict that going forward, this will be a part of the problem that we will face.
Okay, thank you.
So have you treated Bethesda category 4 nodules?
Yes, I have. When patients truly decline, but they must look quite benign on ultrasound. So if they look echogenic, they look smooth, I have less of a problem. Now, Dr. Lin again has a paper on PET for follicular neoplasms. Personally, I'm not too sure, simply because it's very high dose. But certainly from his series, that if you have a low SUV on PET, maybe I think he's co-host now. Maybe we can ask Dr. Lin to have a few words. Yes.
Yeah.
Hi.
Yeah, good night, everyone.
It's so nice to have you here. We were hoping you could, if you could tell us a little about your paper that Dr. Tu just mentioned.
Yeah, I appreciate this opportunity. Let me online to answer this critical question about follicular neoplasm. Actually, just an appearance of Dr. Tu. A lot of patients, initially, they would not like to treat their goiter, but once, again, one doctor had do fine needle aspiration, and it become atypia or follicular neoplasm. The patient become nervous. So they come to us for the thyroid ablation. But even that we do the core biopsy through the capsule, we still cannot prove it 100% that is a benign nodule. So we found a series of papers published using a PET and a retrospective found that if the SUV number is low enough, such as less than 4, the benign molecular negative predicted rate can achieve very high, such as 95 to 98%. So only 2% of them, if they go for a surgical resection, it will turn out to be a malignancy. So we will explain to our patient if they accept the risk of the 2 to 5% of malignancy from the follicular neoplasm, and then we will do the operation for them. Yeah, that's my experience. So now for patients with follicular neoplasm, we will explain to them that go for the PET study, and we check if we can help them. Thank you.
Okay, thank you so much. That is very good data to explain to our patient first. Okay. So I have one last question. So any of you doing the ablation in the functioning nodule? And so if we have that, so do we have to control the thyroid function first, or what is the pre-medication before doing this kind of case?
Yes, I have treated some patients with functioning nodules.
Yes.
But most of them are very small, like 2 to 3 centimeters. It cannot be.
Oh, Dr. Xu, so we cannot hear you.
The connection is breaking
Okay,
up.
I mean, I have treated several patients with functioning nodules, and these nodules are in the maximum diameter. It was in the range of 2 to 3 centimeters. I would not recommend a larger nodule, like maximum diameter was over 4 centimeters. It's not good candidate for some ablation, I think.
So do we need to control the thyroid function before treatment this kind of case?
Sure. And we also treated some patients with grave disease because of the goiter. The patient was complained of the cosmetic problem, particularly in young female. And I found that thyroid stimulating thyroid hormone receptor antibodies was elevated after ablation. One female patient was found to have Graves' ophthalmopathy after microwave ablation. So I think it's more like a radioiodine therapy for Graves' disease. So I also treat some patients with rituximab, which is a mono antibody to treat Graves' ophthalmopathy. And we found that the TRAB level was significantly reduced after the combination of some ablation and rituximab. So I think we should control thyroid function before we start. And I think this not just their anti-thyroid drugs. We should evaluate their thyroid function 2 weeks after ablation and decide whether to discontinue the anti-thyroid drugs.
Okay, thank you so much. So I think we come to the very end of the session. So thank you for all attendees and all speakers to giving us not only the lecture and also the answer the very interesting question and also the case discussion as well. So before we end off the webinar, so any last word from all the speakers? So maybe some last word for all of you. Maybe start with Dr. Xu first.
Thank you for your invitation, and I'm glad to share some of my points. And I hope to meet you guys more frequently online. Thank you so much.
Okay.
Dr.
What
Chu?
about, yeah. Dr. Sheng or Dr. Chu?
Okay, I think before you start, maybe attend a course. The procedure itself is not wildly difficult, but I think it pays to have a look. And I think most of us have, I mean, most of us here have been to Professor Beck and just watch him do a couple. So I think that is great advice, actually.
The course, is that available in the SGCR wires next year?
If you ask, I'll make one for you, Samran.
Okay, Dr. Sheng, is there any last word to all of us?
Yeah, I think thermal ablation for the synovial nodule is currently very popular in the world. So I think we have to learn this technique, no matter how IFA or microwave, both of these different modality can really help the patient, but we still have to overcome some learning curve. After that, we really can give our patient very good treatment result because the patient just received local anesthesia and the treatment result was really, well, the treatment result are really very good, and it just I think the whole procedure is much comfortable than surgery. Yeah, it's just my personal opinion. Thank you, and thank you for Echo Company for giving me this opportunity to share my very preliminary experience, and also I can see my good friends online.
Okay, so thank you everyone, and also very importantly, thank you for the ECHO for organizing the good and wonderful webinar. So hope we can follow the webinar from this company and see you next time. So have a good night.
Have a good night. Thank you.
Thank you very much. Thank you. It has been an excellent session.
Thank you.
Thank you. Bye.
Thank you.
Good night.
Thank you. Good night.
See you
Good
next
night.
time. Bye.
Yeah, see
next
you.
time.
Dr. Bank, see you next time.
See you.
If